Two, one, we are live.
Thank you. So a very good evening to all of you. And I, on behalf of the Indian Society of Cornea and Keratorefractive Surgeons, welcome you all in this webinar on some interesting ophthalmic procedures, which is normally done in general practice. And we have with us today Professor J.S. Tityal, who is the President of ISCRIS and Chief of RP Center AIMS. He is a well-known academician, has multiple publications and presentations, many awards. His credit, especially the most coveted Padma Shri from the Government of India by the President of India.
Rajiv. Rajiv.
Dr. Rishi Mohan, he's the Vice Chairman of ISCRIS. He did his MBBS from Maulana Azad Medical College, New Delhi, MD from RP Center, followed by his DNB, FRCS and MAMS. He did a 5-month clinical registrarship in phacoemulsification from Prince Charles Eye Unit at Windsor, UK. He was awarded the membership of the Academy of Medical Sciences in 2006. He was the best resident of the RP Center for Ophthalmic Sciences at AIMS in 1986, and he has held various positions at academic bodies associated to ophthalmology all along. Welcome, Dr. Rishi Mohan.
We also have with us Dr. Rajiv Mukherjee, who is the Treasurer of ISCRIS and Director and Senior Consultant in Mukherjee Eye Clinic, New Delhi. And he is also a visiting professor at Feinberg School of Medicine, USA. And an established cornea and phaco surgeon and a very good academician. We welcome Dr. Rajiv Mukherjee in this webinar.
Dr. Venkatesh LK, MD at AIMS with a gold medal, DNB, FRCS, ex-senior resident at AIMS in the oculoplastic orbit and ocular oncology with pediatric ophthalmology. He has completed DNB in ophthalmology in New Delhi, followed by FRCS at Glasgow in 2006. He subsequently was a senior registrar in oculoplasty orbit oncology and pediatric ophthalmology at AIMS, New Delhi, and was awarded Best Senior Registrar for the year 2007. He was later heading the Department of Orbit Oculoplasty and Ocular Oncology at Narayan Nethralaya in Bangalore. His areas of interest are oculoplastic and orbital surgeries, pediatric ophthalmology, refractive surgeries. He has presented various papers, posters, and presentations in state and national conferences, and he has various publications in national and international peer-reviewed journals. Welcome, Dr. Venkatesh.
We also have with us Dr. Milind Changole, who is Director, Eye Sparsh Hospital, Pratap Nagar, Nagpur. He has done his MBBS from Nagpur and then came to RP Center. He did his post-graduation from RP Center AIMS, and then he became senior resident of RP Center and then also joined the Nagpur Medical College as a consultant. He is known for his wonderful surgeries, and he is a very good academician. And we welcome Dr. Milind Changole in this webinar.
Dr. Devraj Shom, Director and Co-founder of Aesthetics Clinic, Mumbai. He is MBBS, DO, DNB, FRCS, and FACS, FAACS, American Board Certified in Facial Cosmetic Surgery, Fellow American Academy of Cosmetic Surgery. He is member of various ophthalmology-related societies all over the world. Super specialty trained in cosmetic facial plastic surgery from Salt Lake City, Utah, USA. Super specialty fellowship trained in the Department of Head and Neck Surgery from MD Anderson Cancer Center, Houston, Texas. Super specialty AOCFM fellowship trained in craniomaxillofacial surgery from Morriston Hospital, Wales, UK, and an MBA Health Management from Vanderbilt University, USA, and National University of Singapore, 2008. Welcome, Dr. Devraj.
We have with us Dr. Amrita Sindhu, who is a consultant at Arvind Eye Hospital, Coimbatore, a young, very dynamic oculoplasty and pediatric ophthalmology consultant. She is also a medical officer in the same hospital at Arvind Eye Hospital, Coimbatore, Tamil Nadu. And she is a very good teacher, very popular amongst the fellows, very actively involved in teaching of fellows at Arvind Eye Hospital, Coimbatore, and has many publications and presentations to her credit. We welcome Dr. Amrita Sindhu in this webinar.
Dr. Nikhil Gokhale, a wonderful person and a close friend, director and co-founder of Dr. Nikhil Gokhale Eye Clinic, Mumbai, MBBS, University of Delhi, 1989, MD Ophthalmology from AIMS, New Delhi in 1992, did his DNB in ophthalmology in 1993. He did a fellowship in cornea, LV Prasad Eye Institute, Hyderabad in 1995. He's an astute academician and a wonderful surgeon, a great person to have with us. Welcome, Dr. Nikhil.
It's a great privilege to introduce Dr. Sujata Das, who is Medical Director at Dustidan Eye Bank, Mithu Tulsi Chan Rai Campus, Patia, LV Prasad Eye Institute, Bhubaneswar. She has done her postgraduate training at Behrampur University and then went on to do subspecialty training at LV Prasad Eye Institute, Hyderabad, in the cornea and anterior segment, and then did her fellowship from the University of Erlangen, Nuremberg, Germany. Then she did fellowship in cornea at the Royal Victorian Eye and Ear Hospital at Sarah, in Australia. She has also received many awards like the Developing Country Eye Researcher Award, the Arvo Foundation, the AIOS Gold Medal, B.K. Narayan Rao Oration Award, and many other awards, and has various articles in peer-reviewed journals, more than 75, and is a reviewer to various prestigious journals. She is a true academician, and we welcome Dr. Sujata Das in this webinar.
Dr. Alok Sen, a senior consultant retina services, Sadhguru Netra Chikitsalaya at Chitrakoot. He's a medical superintendent and head of department vitreoretina and uveitis. He did his MBBS from Nagpur University in Maharashtra, MS from Nagpur University in Maharashtra, the same place, fellowship in vitreoretina from Sadhguru Netra Chikitsalaya, observership at Moorfields Eye Hospital, UK. Dr. Sen has a vast experience of handling complex cases in general ophthalmology and especially in vitreoretinal and uveitis disorders and uveitis cases. In various national and international conferences, he has presented as a seasoned surgeon for cataract and retinal disorders. Welcome, Dr. Sen.
We also have with us Dr. Raju Sampangi, who is Director and Vitreoretina Consultant at Netra Spandan Eye Hospital, Bangalore. He has done his postgraduate training in ophthalmology, registrarship in vitreoretinal services at RP Center, AIMS, New Delhi. He has published several scientific papers in international peer-reviewed journals, has presented papers, videos, and posters in various international and national conferences, and has previously been associate editor of DOS Times and chief editor of Chakshu, Journal of Karnataka Ophthalmic Association, and has conducted instruction courses on sterilization in national and state levels, has innovative solutions for HD 4K surgical video recording using commercial cameras, winning abstract at Retina World Congress, Florida, USA. Currently working on 3D surgical recording systems. We welcome Dr. Raju Sampangi in this webinar.
Thank you, sir.
Professor Namrata Sharma, Chairperson, Scientific Committee, ISCRIS. She's Professor of Ophthalmology in Cornea, Cataract and Refractive Surgery Services at Dr. RP Center for Ophthalmic Sciences, AIMS, New Delhi. Notable affiliations among many are she's the Regional Secretary, Asia Pacific Academy of Ophthalmology, Secretary of the AIOS, Secretary, Eye Bank Association of India, Chairperson, Scientific Committee of Indian Society of Cornea and Refractive Surgeons. She has a huge amount of academic and research-oriented achievements to her credit. A few among them are 380 publications in various journals, 19 books and chapters. She has authored more than 11 books, actively involved in teaching of undergraduate as well as postgraduate students via various teaching programs, has been conducting numerous instruction courses and has been invited faculty at various national and international conferences. We welcome Dr. Namrata Sharma.
I welcome all the panelists and the speakers in this webinar. And before we actually go to the scientific session, I will request our President, Professor Tityal sir, to say a few words.
Thank you, Rajesh, and good evening to all our friends who have joined us today for this very, very interesting procedures which are done by all of us, especially general ophthalmologists. And interestingly, looking into the speakers, I think they are the young brigade going to take country forward, and they are experts in this field. And equally good are our panelists. So I'm very excited to go back to my own journey, looking into a syringing and probing, which Venkatesh is going to talk about, and few newer areas of injections. I think injections have become very prominent in ophthalmic practice, right from the intravitreal to subtarsal injections. I think it should be a very interesting for all of us, especially the general ophthalmologists and young people, because most of the manual books may not give you exact technique of how to inject these things, especially Botox. So this will be a great learning for all of us. And I would definitely like to give a thumbs up to Rajesh, Namrata, Rajiv for organizing this type of webinars where we have basic procedural aspects, how to do correctly, and what are the outcome of these procedures. Let's see and enjoy the entire session. Thank you, Rajesh.
Thank you, sir. And our first speaker, Dr. Venkatesh, who has been part of RP Center earlier, now practicing in Bangalore, will let us know about the nuances of syringing and probing. Venkatesh, please.
Thank you, sir. Thank you, TDL sir, Namrata Sharma, and Dr. Rajesh Sinha for giving me this opportunity. Today, I'll be presenting on syringing and probing, when and how to do it. Whether the screen is visible, sir?
Yeah, it is visible. Just make it full screen.
Yeah. So when should we do syringing? Whenever a patient presents with watering and we suspect blockage in the lacrimal drainage system, then
Venkatesh, make it full screen.
say it's full screen.
No, you just have to go down and click that icon, full screen icon.
Slideshow.
Yeah, slideshow. Yeah.
Slideshow is there on the top, no? 1, 2, 3, 4.
But it's there down.
Seventh icon. It's there down also.
Yeah.
Otherwise, seventh
Madam,
icon on the top.
On my screen, it is showing full screen only, madam.
Okay, then maybe you'll have to reshare it. Just unshare and reshare.
Unshare and again, yeah.
Yeah, just reshare it.
When you open, you don't open full screen, no, on your laptop.
Yeah, yes.
Yeah. Now, yeah. Now
Now
click.
is it fine?
Still not coming.
You are clicking full screen, but for us, it's not full screen. For you, it is full screen.
Yeah.
How is it possible?
Yeah. Maybe you can just go up, click
Yeah,
slideshow.
perfect.
Yeah, perfect.
Yeah.
Perfect. Yeah, yeah.
Thank you. So when should we do syringing? As I was just telling, whenever a patient presents with watering and we have ruled out any irritation part and we suspect blockage in the lacrimal drainage system, then we should do syringing and probe test to confirm at what level is the blockage. So the blockage can be at the punctum level, canaliculus level, common canaliculus, or nasolacrimal duct level. So the common presentation will be watering. Simple watering means one should suspect either punctum, canaliculus, or common canaliculus. And if it is associated with discharge, then commonly NLD block is the suspicious thing. They can also present with direct swelling at the lacrimal sac area with pain. And this can be presentation even in the child also. So check for the how to check the patency of the lacrimal drainage system. So we start inspecting the punctae, then regurgitation test, followed by syringing and probing test. So normally both the punctae should be widely open and it should oppose the conjunctiva. The punctal stenosis or blockage or atresia can be in the lower or upper punctum, but even if one puncta is open, usually they don't present with any watering symptom. So regurgitation test, we generally press in the lacrimal sac area. 1 minute. So we have to press in the lacrimal sac area, and if we see this purulent discharge or mucoid discharge coming from the punctae, then it clearly indicates nasolacrimal duct obstruction. If regurgitation test is positive, then no need of doing syringing. It clearly indicates nasolacrimal duct obstruction. If it is negative, then we try to find it out by doing syringing and probe test to find at what level the blockage is. So how to do syringing? Sorry for the videos are not. It's done under general. So generally punctum dilatation should be done. With a different punctum dilator, one can do it. This is a probe test which I'm showing it. And once we start pressing the probe, we can either notice a soft stop or hard stop. And if it is a soft stop, when we push the probe, the medial canthus sometimes goes inward. Then it indicates either common canalicular block or canalicular block. This is usually we measure it on the scale to know the length of the blockage. So NLD level blockage, whenever we do syringing, it will give a delayed regurgitation from the opposite punctum or through the same punctum with mucoid discharge. In common canalicular level, immediately from the opposite punctum, we'll get a regurgitation. In canalicular level, there will be immediate regurgitation of the fluid from the same punctum. And this is the probe test which I just showed. Type of stop, is it soft stop or hard stop? And length of the stop, we have to measure it. Less than 3 to 8 millimeter, usually in the canalicular level, 8 to 10 millimeter common canalicular, and more than 10 millimeter of the probe test will give it is in the NLD level. And normally in the nasolacrimal duct blockage, one can feel the bone touching with the probe actually. Once this is done, the syringing and probing test can be done even in congenital NLD blocks. Commonly, there can be a membranous blockage in the lower NLD area, usually in the 75 to 97% cases, which generally opens with syringing and probing test. And some children can have nasolacrimal duct obstruction also. I'll show the syringing and probing in a pediatric patient. Generally, this is done under general anesthesia. Done under general anesthesia. Lower, so and upper punctum. Usually lower and upper punctum are dilated. Normally, a betadine solution is injected to check for the patency. If it is not coming up, through the upper punctum, gradually manipulated until it reaches the nasolacrimal duct. Probe action should be properly assessed, and probe is then advanced downwards, posteriorly and laterally until a gives. Cleaning is done to enlarge obstruction. Repeat syringing is done to check for patency of nasolacrimal. We usually do this betadine solution, and one can see betadine coming suction drainage. If there is a bony stop, then usually the regurgitation will not come over. Sometimes we try to fracture the low inferior turbinate, and even if it fails, then there can be a bony stoppage. Later on, at the age of 4 or 5 years, one can plan for intubation DCR. Thank you, sir.
Thank you, Venkatesh, for a very crisp presentation and some nicely shown videos. Can we have Dr. Milind's opinion on this? Can you just unshake, Venkatesh?
Yes, sir.
Good evening, everybody. Thank you for this opportunity. And Dr. Venkatesh, it's nice presentation. Syringing probing is very commonly done procedure for a therapeutic and diagnostic purpose. So it is nicely summarized. There are something one always do before the cataract surgery as an anterior segment one has to do. And as sir highlighted, it should always start with the punctum dilator, followed by a syringing and then probing. So thank you, sir. In pediatric cases, the most important things which one should always highlight is age of syringing probing, which is generally many anterior segment don't follow. Is it should be between 9 months to 15 months, which should be ideal. And after the 15 months, though the success rate is there, it's fall down. So it should be encouraged in between 9 to 15 months. And before that 9 months, its role is controversial, but can be done in tricky situation. Thank you, sir.
Thank you, Milind.
So thank you, Dr. Milind. A couple of questions for you, Dr. Venkatesh. One is that till what time one should go ahead and keep doing the sac massage? This is something which...
one thing is, especially if child, as Milind was telling, up to 9 months to 1.5 year age, or ideally 1 year age, we consider to be the ideal age for doing it. Until that time, the sac massage can be continued. And doing the sac massage is very important. And generally what I advise is press in the medial canthal area here, just only twice a day. Repeatedly doing it doesn't carry any meaning at all. I ask the parents to press it 3 or 5 times each sitting, usually in the morning and once at night. Especially ask the mother while the baby is being fed, feeding time, they should do it. And if any other indications are there, for example, if child has NLD block and there are some emergency indication like child has cataract or something, wherein which we want to proceed with cataract surgery or congenital glaucoma or something, where urgent surgery is needed, intraocular surgeries. At that time, one can intervene in between and go ahead with this syringing and probing.
Dr. Nikhil has written that there's an article wherein it has stated that syringing isn't needed before cataract surgery if regurgitation is negative. That is very true. We completely, agree with that. Dr. Alok has written that there's a recently published article from their center in which syringing versus Roplas was compared in a large series. Dr. Alok, you would like to say something on that?
So, sir, this was a retrospective study, and this was basically during the COVID that we had stopped doing syringing in our cases. And so we retrospectively analyzed the incidence of endophthalmitis and all, but it was different from pre-COVID era where we were syringing in all our cases, and we found no difference. So it was a surrogate marker that you can use either. Of course, Ravi Thomas sir had published an RCT way back into early 2000, where they had shown that there was no difference between the two. Just we had a series of 45,000 patients pre-COVID and post-COVID, 45,000 post-COVID during the COVID period.
That's huge.
Yeah, the clinical assessment is most important. If there is a increase lacular amylase, then only we can one should do a syringing probing. Otherwise, there is no need as such. So clinical suspicion for a NLDO, there should be this point should be ruled out apart from ROPLAS. These 2 points are important before going ahead with syringing probing.
Rajesh, may I ask a couple of questions from Dr. Venkatesh? Very nice presentation. Thank you so much. 2 quick questions. One is that how important is it to continue a sac massage after a successful syringing? Is it important? That's the first one. And the second is, if the first syringing fails, what would be the course of action for doing a second one? How soon can we do it?
So first question, sac massage, generally, once we do syringing and probing, on the table only we come to know whether it has been opened up or not. If it is open, probably ask the parents to continue for a 3 weeks to 4 weeks time, so that it should not get reblocked. And especially antibiotic with steroid, commonly I give dexamethasone with most of the antibiotics for a week's time, so that whatever the inflammation we have induced during probing, that should subside and it should not lead to reblockage. And whenever, if a surgeon is really confident enough, usually in the first sitting only we can come to know generally whether it has opened up, is it a bony blockage, or if it is a membranous blockage or what. If it is bony blockage, probably if it is really not this thing, inferior turbinate fracture can be tried in the same sitting, or probably in the second, probably after 3 or 4 weeks, one can go ahead with the second syringing attempt. If that also fails, then probably wait for some more period, and later on, once the child slightly grows, then the DCR surgery will be much more easier to do. And the fibrosis part, which we commonly see in children, the common cause for a DCR failure, will be much more lesser with the older age group.
Okay. So that would be an endonasal approach would be preferred, or conventional DCR then again in these very young kids?
Say in kids, main thing is fibrosis. So larger opening, we try to expect it. With an intubation, DCR is the indication one. So I would prefer external DCR rather than endonasal, sir.
Okay.
Dr. Nikhil has a comment. Dr. Nikhil.
No, I was just saying that just what Rishi was saying, sometimes, the patient has had some sort of probing procedure elsewhere. So we don't know. And if he comes for opinion, before we tell him do a DCR or something like that, we may have to repeat it, or, to be sure really requires a DCR. So I was just saying that there may be occasions when we may have to repeat it. Maybe sometimes someone else has done earlier, possibly.
Okay. Rajesh, can I make a comment?
Sir.
I think, it is like any management, any oculoplastic procedure, there is you have a best chance to succeed in the first time. So everything has to be done in a very appropriate manner. And it is done in infants normally, as you rightly pointed out, between 9 months to 15 months. Therefore, you should not take lightly. I've seen people doing probing without general anesthesia, which can create a lot of other complications. So it should always be done in a proper anesthesia, most probably general anesthesia, so that and patient should be, if possible, intubated, or you can just do a laryngeal intubation also, and do in a proper, you can say anesthesia, so that patient is relaxed. So that is one important point should be considered. As Nikhil was saying, most of the failures people are reported because they've not taken a proper precaution. And repeat can be done to assess if previous attempt has been done in a proper manner or not. And it's important to do a probing. Syringing is easier sometimes, but even syringing can cause complication. Your punctum can be damaged. So it is you have to be very careful. Once it is damaged, that can form a fibrosis and punctum can get closed. So use a proper instrumentation is also very important there. And probing also, the major complication, we know that it can cause a punctum tear or an enlargement of punctum. You can create a false passage, especially in the infantile cases. False passage can happen if you are not done proper way. You think you have a soft blockage and try to open that, you are in some other space. So that has to be taken very carefully. There are few things which needs to be observed. When after probing, you feel you are succeeded to open the membranous block. When you are looking into these patients, apart from doing a syringing in such cases, the patient is under anesthesia. They don't know what is patency wise. If you, with a suction, if you see a little bit of blood, then you are pretty sure you have succeeded in opening the membranous block also. So simultaneous suction also will give you idea if the fluid is going through your syringing after probing. A little blood also indicates that the opening has been created nicely in these cases. As far as bony block is concerned, rightly pointed out, you should not proceed further. You just measure exactly where is the bony block. Maybe wait for some more time, let a child grow, and you can do a DCR in such cases. But patients will go in many places because they continuously have a watering and discharge, and it's very difficult to take care of these people. Most of the failure of massaging, what Dr. Rishi was talking about, is basically because of an improper way of handling these infantile cases of massaging. Properly done massaging, more than 80% of cases, they open up itself or they improve themselves within a period of a few months. The proper way of massaging should be told to these people. So I would like to really stress that proper instrumentation has to be there. That means you should have a good punctum dilator, and the probe should be selected in a right way to size wise. So you have a 0 to 4. So you have to actually appreciate which size should go for that particular case. Normally it's selected properly, you have a lesser chances of damage to the canaliculi, the entire drainage system in these cases. And multiple requirements are very less. There are very few chances that you may have to do second time. And as Venkatesh rightly pointed out, if you use a antibiotic steroid drops for another 2 to 4 weeks, normally that will suffice in these cases. You don't have to use any antibiotic drug in a probing and syringing, which people use in DCR surgery.
Venkatesh, any comment on the size of probe in cases, different cases?
Generally, we start with 0 to 1. And one important thing while doing syringing probing, actually, we can feel that give way. Usually, an experienced surgeon, once he just passes the probe in the inferior and lateral direction posteriorly, one can feel that give way, that membrane has already given way. And gradually, like probably with the smaller one, we can start it. It should not be too small also. Generally, I do with 1 number probe. And if required, another 2 number we can go and do that reaming rotation, actually. That enlarges the nasolacrimal duct inferiorly. And another what we commonly used to do in RPC, because in RP center, probably, sir, you know it. So many cases we used to do in a single OT. So we can pass another probe through the nose and feel that metal to metal touch. If that is there, then it indicates that it's open actually.
Wonderful. Any other comment?
There are other ways to check. One is you can actually sometimes see the glint of the metal if you use the light from the laryngoscope. The other option, one of the indicators that Dr. Tyal was saying was the appearance of blood. That's always a giveaway that there has been a penetration of the membrane. But one can also use a little trypan blue or methylene blue in the water for the syringing, and that instantly stains whatever is coming in the nose. And that's something that I've been doing from RPC days, and it works wonderfully well. The cuffed endotracheal tube business is also extremely important to prevent aspiration for these children. And in that age group, usually cuffed endotracheal tubes are not available in that size. So one has to then pack the laryngeal area with the gauze. And once you pull the gauze, you can see the blue color in it. And that's always a perfect way to tell that you've been able to be, you were successful. Just some observations thought I'd share.
Yes, absolutely correct. I think that, cataract surgery point of view, Rishi will remember in all days, We had to do a test bandage to every patient admitted, and the syringing has to be a compulsory part of these. And that is a major, workup for for us. Luckily, it's not been done, and it's not required also. And
but
thank
phenomenal
God.
training. Phenomenal training.
Yeah. And taking an intraocular pressure with shear tonometer. Oh my God, those were days.
So thank you, sir. And now we move on to the next talk, and that is by Dr. Devraj Shom, who will be talking about Botox injection. Dr. Devraj, will you be sharing or I should share? Dr. Devraj?
Yes, sir, you can share, sir, because I am in transit. So as a result, good evening. Good evening to everyone. It will be better if you share, sir.
Yeah, I'll do that. Yes.
Some disclosures are necessary. I have been a faculty and a trainer with the Allergan Medical Institute for Asia Pacific. This is the company which makes the botulinum toxin. I have also been a trainer with 2 other related companies for the past decade. Botulinum toxin is now utilized in over 28 plus indications all across the body. But the first uses were as follows.
डॉक्टर सू कैसे बोलो जो टाइम पे बात करता है ना उस टाइम पे थोड़ा ज्यादा बंद हो जाता है
So in patients who have blepharospasm or hemifacial spasm, 2 conditions in which the eyelids continuously end up closing by themselves, it can become a huge problem. So from that perspective, it becomes very important to treat these patients appropriately, and that is where botulinum toxin first started getting used. So spasm-like conditions, botulinum toxin started getting used first, and that led to the spasm disappearing. But we also realized that this was removing the wrinkles around the eyes and around the forehead, which in turn led to botulinum toxin being used for facial aesthetics, which in turn started off a new concept completely of facial aesthetics and looking younger using Botox.
Hemifacial spasm is a nervous system disorder in which the muscles of one side of the face twitch involuntarily. As you can see in this patient, that her left side of facial muscles are constantly involuntarily twitching. This can, if not treated, lead to the complete closure of the eye and also can affect mentally, psychologically, and even in social settings of the patient. The initial symptoms of the hemifacial spasm can range from frequent eyelid blinking, leading to closure of the complete eye, and redness and irritation of the eye, dry eyes, and even involuntary constant muscle twitching. The causes of hemifacial spasm can vary from being a vascular compression, facial nerve compression by a mass, brainstem lesions such as stroke or multiple sclerosis, and it could be secondary to trauma or Bell's palsy. The treatment options include microvascular decompression, which relieves pressure on the facial nerve, injections of the botulinum toxin into the affected area, or duct therapy. The surgical treatment has potential side effects, whereas the drug therapy is not much effective. Hence, the botulinum toxin injections in the affected muscles work well and give relief with almost no side effects. It is an in-office procedure and can be done in 30 minutes. Here, as we can see, there are different marking points for benign essential blepharospasm and for hemifacial spasm, which is a more complex disease. Now, in benign essential blepharospasm, as we can see that it is always bilateral involvement and leading to constant eyelid muscle twitching. The B stands for 4 units of Botox, and in the upper part of the eyelid and or over the forehead, total 4 units at each of these points is given, whereas in the lower part of the eyelid or the lower eyelid, 2 units each is given. In hemifacial spasm, muscles of the half side of the face are involved, and hence more points of Botox injection or botulinum toxin injection are needed. As we can see here that the forehead point, that is the glabellar point, the eyelid muscle points, even the nasolabial fold, the corner of the mouth, the chin and the mid part of the cheek are injected with 2 units of Botox or the botulinum toxin. Let's see the demonstration on the patient with the injection of the botulinum toxin. As you can see in this, there is immediate relief of some of the symptoms of constant muscle twitching of eye muscles, as well as the nasolabial twitching and even the corner of the mouth. Thus, the botulinum toxin injections in benign essential blepharospasm and hemifacial spasms proves to be safe and effective for relieving the patient of the discomfort and providing a better quality of life.
So in general, as we understood, blepharospasm and hemifacial spasm is where botulinum toxin started getting used. And then we moved on to using this for removing lines. Now, some things need to be understood for using the botulinum toxin in facial aesthetics. One thing to remember is that a lot of specialties, including ophthalmology, ENT, oromaxillofacial surgery, dermatology, and plastic surgery, are now into facial aesthetics. And in fact, if you look at the American Board of Facial Cosmetic Surgery, ophthalmologists form a large number of them, those who have completed a primary ophthalmology residency, and as many as 40% of the American Board of Facial Cosmetic Surgery diplomates come from an ophthalmology background. So understanding facial aesthetics becomes very important for these residents. Now, facial aging is basically mother gravity being ever so kind, and mother gravity pulling us all downwards and medially all the time. And that's basically what is aging. Then anti-aging must be moving the same facial tissues upwards and laterally. Now, we performed India's first aging trial a couple of years ago, and it's really something that we weren't proud of, in the sense that India did not have any data on how Indian faces were aging. So in India, facial aesthetics involved treating Indian patients based on how Caucasian data was coming up. Now that doesn't work. So as a result of which we conducted India's first aging trial. And if it was a photographic documented study, and if you look at this, you can clearly see how Indians tend to age, how this lady has aged from 23 to 37 to 71, and then how she's aged at age 76. Similarly, this lady going from 20 to 34 to 45, and then at age 51, and then this gentleman 40, 75, 86, etc., or this lady at 28, 40, and 49. Basically, the upper thirds of the face ages very well. It is really the mid face and the lower face which are problem areas. And if we remember clearly, botulinum toxin for facial aesthetics is mainly used in the upper third of the face, involving the periocular areas on the forehead. And therefore, Indian faces are more thread and filler faces, which are used to treat the mid face and the lower face problems, rather than botulinum toxin cases, which are used to treat the upper face. Because we don't have, because of the melanin in our skin, we don't have as much facial aging in the upper third as many of the Caucasian races do. However, it's still worthwhile to really understand how Botox works. And the periorbital features are actually the most important. What happens is, because this part is blinking the most and the under eye skin is also the thinnest skin in the body, this undergoes more aging than other parts of the face. And especially in a mask-driven world, this is the part of the face which is also most seen by others. Therefore, it makes sense to treat this part and to make the face look younger and more rejuvenated. Now, there are many reasons for aging, but basically evaluating the aging, figuring out how to treat the patient becomes very, very critically important. So we evaluate the face and then decide the next steps before moving into the treatment. So this is a very detailed presentation. It really talks about facial aesthetics in general. I don't think we have the time for this, but in general, before using botulinum toxin, a medical history, assessment, etc. becomes very important. And that is when you'll be able to understand why the patient is aging the way they are, what their motivations are, and how we can treat them better. Taking an informed consent is extremely important. In fact, the first things that we do is to make sure that we take an informed consent, we take good quality photographs so that there can be documentation which allows us to evaluate how the patient did post the treatment. Understanding the anatomy of the upper face is the most important. Like I said, the under eye skin is the thinnest skin of the human body and therefore shows the earliest signs of aging. Also because it continually goes ahead and blinks. And understanding the muscles like the frontalis, the procerus, the corrugators, and the orbicularis becomes very, very critically important as well. In general, the orbicularis oculi is the muscle which is responsible for closing the eyes. It's made up of 4 basic different parts of the muscle. And they are also responsible for the crow's feet, which a lot of people get at the side of their eyes when they are smiling. Treating the crow's feet is very, very simple indeed. And basically, we have to relax the orbicularis, paralyze is the long word, such that the dynamic crow's feet become less visible when the person is smiling. These are the muscles. The procerus and the corrugators are always injected together. They are brow depressors. And by reducing the activity of the brow depressors, we can get the brows to go higher, which in turn makes the entire periocular part look much more relaxed, and also removes the excess skin which is over the eyelid, which mistakenly some people, even in early patients, remove by blepharoplasty, but actually it's a brow ptosis which is causing that excess skin. The orbicularis oculi and the depressor supercilii are also shown in this particular photograph. Now, the botulinum toxin itself, as we've spoken about, is a 900 kilodalton molecule. It's made up of it's basically a neurotoxin. It goes in and stops or cleaves the acetylcholine, which is in the neuromuscular junctions. And by going ahead and doing so, it chemically denervates the muscles. And in that, therefore, the results last for about 3 months until the muscles and until the nerve endings grow back again and the acetylcholine starts getting released again. Now, there's a certain circle of diffusion of the botulinum toxin. You need to be certain that your injection points are a little bit, approximately about 1 inch away from each other. And there are other things which need to be taken care of as well. There are many types of botulinum toxin. We use the Xeomin, the Botox, the Dysport, all of them very frequently. It's important to remember that each one of them behave differently, and therefore one should not be used for the other blindly. Now, we use this in the face on glabellar lines, crow's feet lines, and also on the forehead lines. And that's how botulinum toxin is injected for the glabellar lines. You might have seen one of the injection points in the earlier video. And that's how it is injected for the crow's feet line. Obviously, you need to be careful because if you involve some other muscle, you can also cause crooked smiles, etc. So it's important to take care of all of these things and have a thorough knowledge of facial anatomy. That's how it is injected in the forehead without going too close to the brow. We keep 2 fingers, we stay 2 fingers away from the brow. The idea being that the brow can then be elevated and it does not cause any brow ptosis as such. Now, reconstitution is most important. Reconstitute the botulinum toxin with 0.9% sterile non-preserved saline, and that's what we use. We basically use 2.5 ml of the saline into 100 units of botulinum toxin, which basically gives us 4 units of the Botox per 0.1 ml. We tend to store this in the side, the door of the fridge, and you can actually store this in the door of the fridge for even 6 weeks. As long as the cold chain is maintained, the Botox works exactly the same. There's no problem with that, and we published a paper on that a few years ago. That's how the injection points are decided, and that's the various depths of the injection for the glabellar lines, and that's how the injections are injected. You use the thumb and the forefinger to hold the muscle, and then make sure that you go to the appropriate depth and inject the muscle, clearly understanding where the muscle lies, and therefore, to repeat again, facial anatomy is critically important. That's how the Botox is being injected. And this is for the crow's feet. Again, these are superficial injections because, as you remember, the orbicularis oculi is just below the skin, and you can inject the botulinum toxin easily. Away from the eye is what we recommend in those people who are worried about perforating the eye or getting into the eye and causing other side effects. So on the forehead lines, depending on the forehead lines, we inject the botulinum toxin. It's injected in between the lines, and basically we leave an area above the brow which is not injected, so that we can have the brows going up, because the frontalis is the only elevator of the brows, and instead of going too close and causing brow ptosis. That's also how we can use the grid pattern in injecting the forehead, and that's the forehead being injected. You can see that the marking is done with the pencil before the injections are done, and then the injection is given 1 millimeter away from the marking. You don't want to go through the marking, because that in turn can cause some impregnation of the marking pencil marks below and tattooing of the subdermis. So I want to now talk about some patients. This particular patient came into us, and she complained of eye asymmetry. She had already been to plastic and oculoplastic surgeons and had been suggested ptosis surgery. If you look very carefully at her, you can see that the right side of the face is asymmetrical from the left side of the face. The right eyebrow is higher. The right eye has a little bit of inferior scleral show, which is not there on the left side. All of these changes become worse when she's smiling and the left eye looks much smaller. But the question is, it's a difference of 1 millimeter. I don't think we are good enough surgeons to be able to treat 0.5 or 1 millimeter of ptosis predictably in all patients. She's also a model, so as a result of which we need to be more careful. What we did in her was a couple of units of botulinum toxin in the hypertrophic orbicularis oculi, which is just below the inferior lash line. And then we injected a little filler as well. And that's what she looks like immediately after. You can see now when she's smiling, the problem has been sorted. The fillers will last for approximately about 15 to 18 months. The botulinum toxin, on the other hand, will last for 3 to 6 months. But the important thing is, every 3 months also, it's a very small amount which needs to be paid by the patient. And she's very happy not having taken the risk of surgery in that sense. These are the befores and the afters of the same patient. Now, some other patients. This is a patient who is the CEO of a large company, and she first presented to us about 14 years ago. At that time, we only had botulinum toxin. Fillers had not still come into India. Just with the botulinum toxin and one filler which had just come in at that moment, we could transform her from here to here. And that's a massive transformation, as you would tell, and it's possible to create these changes. Botulinum toxin is also something which is used to transform the facial contours. And in people who have very broad faces, one of the major reasons is the masseter muscle, which is at the lower face, is very large. And so using the botulinum toxin makes the muscle smaller, and this can cause semi-permanent results. You can see the befores and the afters in this. And in turn, you can see how the shape of her face has changed. And you would probably say that she's lost many kgs of weight. But actually, the truth is only the shape of her face has changed. And that's how it's a sequential benefits that can be seen. These changes that are seen post-botulinum toxin in the masseters used to be an off-label treatment, but our paper 2 years ago has qualified and clarified how this, what needs to be injected, how it needs to be injected, how soon and how often does this need to be given, and leading to semi-permanent results. And this is now being utilized by the company to actually apply for FDA approval for this indication of masseter hypertrophy. In general, the aesthetic clinics has been at the forefront of research, and we've worked on multiple things all over the last few years and have been at the cutting edge of research in aesthetic dermatology, plastic and cosmetic surgery, and found a number of usages of the botulinum toxin, including using it in scars, etc. And various other things as well that we've worked on and hopefully help take science to the next level. We train people a lot, as you can tell from the passion in this presentation that we love to teach. And facialacademy.org is where you should go to if you want to come for one of our training courses. There are various specialities which come in, including ophthalmologists, plastic surgeons, dermatologists, ENT surgeons, and oral maxillofacial surgeons. And they learn from us. And maybe you want to spend some time in learning how to set up your own facial aesthetics practice. That's a book that we've written. 34 doctors from all over the world have contributed to it. And it's a collection, it's an anthology of heartfelt stories. And it's inspirational. It has been on the Amazon bestseller list for the past 3 years or so. And I request everyone to read it, because especially in these times where we need a little bit of inspiration, this will inspire all the doctors watching this presentation. All in all, I thank you for your kind attention and a patient hearing. If there is anything that you need to reach out to us for, please don't hesitate. And thank you for having me here. And thanks for listening to this presentation.
Thank you, Dr. Devraj, and it was a really magnificent presentation. Before we actually go to discussion, we have another young and dynamic professional in this field, and we have Dr. Amrita Sindhu, and we would like to have comments from her.
So, good evening, everybody. At the outset, I would like to thank Iscaris for providing me this opportunity. So thank you, Dr. Devraj, for this beautiful demonstration of the aesthetic and orbital part of Botox use. As a strabismologist, I think I'll be interested to inject Botox into the extraocular muscles. So I would be covering that part of Botox use, which is not covered by Dr. Devraj. So basically, when the Botox was started, it was started by Dr. Alan Scott. First, he tried injecting it into the extraocular muscle to see whether it works, whether it paralyzes the muscle. That's where the journey of Botox started in ophthalmology. So now it has widespread use in ophthalmology, especially in the strabismology part. So in the strabismology, mainly we use in conditions such as sixth nerve palsy, where the patient is having a very severe diplopia and not able to carry on with his routine activities. We use it in the extraocular muscle, which gives a faster relief than what it takes for a normal course. And also in various causes of acute onset esotropias, where the child presents with sudden onset of squinting and diplopia, botulinum toxin works well. And also in other conditions such as thyroid ophthalmopathy, where there is a sudden onset squinting with diplopia. In the active phase, where we to start with, we can try an open sky technique, where we can try to hold the muscle, we can hook the muscle under short general anesthesia or laryngeal mask. We can hook the muscle, open the conjunctiva, isolate the muscle, and inject directly into the extraocular muscle. But as you get experienced, you can do it without opening the muscle as such. Just hold it with the extraocular muscle forceps, grab the muscle, and you can directly inject the botulinum toxin directly into the muscle. So usually it takes about 1 week to show its effect. We have seen many of the cases where by 1 week to 15 days, the child starts showing, the child becomes diplopia free. And usually it persists for about 3 to 4 months, the child can be diplopia free. And majority of the times, those cases where the onset of esotropia is acute, and if we have injected within 1 month duration of onset, most of the case it is completely resolved. The patient may not get back the squinting again. So this has even been tried in congenital esotropias, where if the botulinum toxin is injected before 6 months to 1 year of age, and if we maintain the binocularity for the child, the very presence of binocularity itself can cause rewiring in the brain, which can completely cure the esotropia. This has also been proven in some cases.
Thank you, Dr. Amrita. And any comments or question from any of the panelists on this topic? Dr. Devraj is actually traveling, so whatever discussion we can have it now. I had one query, Dr. Devraj, that what happens if somebody is in that kind of a transition phase when, one dose has been given, the patient has got some benefit of that, and then after say 2.5 months time, in the transition kind of a phase, any issue, any patient's psychological issue in that when the patient comes back, is going back to the original situation?
So in general, it's a bell-shaped curve. So what that means is before the effect of Botox actually sets in. So Xeomin actually sets in about 72 hours, but Botox, for it to set in, the late responders can take even 10 to 14 days. So generally, once we do the Botox, we wait for 10 to 14 days to call the patient back and to see if he needs any more Botox. So it's a bell-shaped curve. So by 14 days, the effect comes in. And somewhere around depending on the type of muscle, so for instance, in the under eye area where the orbicularis oculi is constantly moving, the dispersion of Botox and the dissemination of Botox and therefore the activity lasts lesser. Whereas if you use it in a place like the forehead, the activity can last even for 4 to 6 months because these parts of the face are relatively immobile. So the effect slowly and steadily wears off. So let's say we do the Botox in the forehead and we are doing it for forehead lines. Slowly and steadily, the lines will start to reappear. So it's not as if there'll be one transition zone at 3 months where everything will break apart. So it's a slow and steady process. It also is different in different people. So for instance, people who are bodybuilders or clench their facial muscles a lot, the Botox tends to last lesser in them because it has been clearly shown that if you use the muscles which are Botoxed, then in that case, the muscles tend to re-innervate earlier. So in general, no, there doesn't seem to be any mental issues with that. And blepharospasm, now there are patients who've been following up with us for every 3 monthly for the last 15 years or so. And even development of antibodies, at least in our practice, is something which is highly overrated in literature. We haven't seen too many of that, despite about 500 patients for blepharospasm being on long-term follow-up with us.
So do you fix up a time like every 3 months, say blepharospasm patients, or you ask the patient to, start feeling that these symptoms are coming back and then you come, what is the kind of follow-up that you follow?
So in blepharospasm, generally the thumb rule is, firstly, I feel that a number of ophthalmologists, especially ophthalmic literature, tends to really give lower doses of the botulinum toxin. So which is why many people find that it lasts only for 6 weeks. Obviously, suppose I'm hungry and I'm hungry for 4 rotis and you give me only 1, my hunger next time for the next meal is going to come up quicker. That's what happens with underdosing. So as a result of which the botulinum toxin needs to be given in adequate doses. In fact, the video which was playing is actually a paper that we are publishing showcasing very clearly that higher units need to be given, sometimes 28, 30 on each side. And once you give those, then what happens is we tell the patients, you be here at 90 days. Don't wait for the twitching to come back, because what we found is once the twitching starts to come back, the bell curve starts again. So it's better to start treating when the dosage is at about 80% rather than wait till the dosage has gone down by a complete 100% and then start from scratch. Also, what we found is, and this is another paper that we are writing, Botox has disease modifying activity as well. We tend to believe that it's twitching, we are giving the Botox, it lasts for some time and then the twitch will come back. But suppose you give it every 3 months, even when the twitch has not come back, we have long-term follow-ups where slowly and steadily we've been able to ease out the Botox to even 6 months. So either the disease is becoming more quiescent or the Botox has some amount of disease modifying activity. So we believe that the twitch should not come back. If the twitch has come back, we are already too late in that sense.
Any other comment or question? Vital sir, Rajiv.
So Dr. Nikhil is saying, I often see dropouts of patients with Botox. That's true, Dr.
Yeah.
Gokhale. Thanks for your comments. But patients, we need to be very clear. I think communication is the most important facet. We would all agree in medicine. And if we tell them right at the beginning that Botox is the gold standard of therapy, whatever surgeries we can do, and I've done a few orbicularis myectomy with sometimes disastrous results with lagophthalmos, etc., is just not worth taking the risk. And when you explain this to patients regularly and tell them to take the Botox regularly, then they tend to be fairly good. Our dropout rate has probably dropped to less than 10%. And these are long-term follow-ups, obviously, with the botulinum toxin being done. So I think with correct communication, we can solve that particular problem to some extent. But good point. Thank you, Dr. Gokhale.
So thank you, Dr. Devraj and Dr. Amrita. And we move on to the next talk, and that is by Dr. Nikhil Gokhale. And he'll be talking about supratarsal injection of steroid in cases of VKCs with giant papillae.
Just a second, just share screen.
Yeah.
So you can see my slide? And,
yes, yes.
Okay. So, well, very frankly, there's not really a big amount to speak on this topic, but we are all aware of that we can have tarsal changes of various grades, which can really trouble the patient. And similarly, we have limbal disease, which can be of varying grades and can really make things worse. And then we have some patients who have everything in the eye, which is really sometimes blinding sort of thing. Another important thing when we talk of cobblestones is to look at patients when they have corneal erosions. I think patients who have corneal erosions need to be evaluated to check what is the area of involvement, because this has a bearing on what you're going to treat them with. So we know it could be cytokine mediated, it could be because of limbal deficiency, it could be because of mechanical rubbing, or it can be because of medications. And then when we have shield ulcers, we need to grade them. Basically, we need to grade based on the severity of disease and the periodicity of disease. And then, as you can see in this chart, supratarsal steroids are basically used for very severe grades of allergic eye disease. So I was just thinking about what would be the real indications. I think, so if you have a patient you come across with severe cobblestones with a lot of inflammation, you try to treat him and the inflammation is refractory and the patient continues to have very severe symptoms, or you see a lot of staining on the upper part of the cornea, which probably indicates that he's having an impending shield ulcer, or I would say maybe macro erosions are there. That would be possible indication. The other patient could be then that you have a patient who walks in directly to you with a shield ulcer. So here you have cobblestones with a lot of inflammation and you need to rapidly control it. You don't want to spend time trying to prove it's refractory or not refractory. So you directly can consider giving a supratarsal steroid. Also to say that there are some patients, especially young adults, where you might see a lot of cobblestones, but they're probably more like just hypertrophic changes. You don't see much inflammation. The corneal staining is negative. So these patients probably don't require an injection per se. And then you will also have some patients who are having extremely repeated cobblestones. They may have history of taking injections in the past repeatedly, and they may have recurrent shield ulcers. They may be refractory to medical therapy alone. So someone like this, where you cannot just keep repeating the injections, you might consider in a very few selected cases doing a conjunctival graft or an oral mucous membrane graft after excising the cobblestones. In general, when we do think of giving an injection, we also need to understand that we need to follow up these patients with adequate medical treatment following the injection so as to suppress the possibility of getting a recurrence. So some of the advantages would be that it rapidly controls the inflammation, and the staining on the cornea usually will come down rapidly once you have given an injection. The effect can last up to several weeks depending on what agent you use. And very often shield ulcers will heal rapidly once you give a supratarsal steroid. The problems could be that especially pediatric age group is where you get these children with shield ulcers. You will have to give some sort of anesthesia. There is a possibility of intraocular pressure rise. Though we may not have too many studies, a thesis from Arvind Eye Institute found that about 13% patients had an intraocular pressure rise. You can also, of course, look for steroid response with drops, which might give you some indication as to whether patient is a steroid responder. There are also possibility that repeated steroid could lead to cataractogenesis, especially when you're also using sometimes steroid drops in these patients. And if there is an infection, it can get worse. So this was one of the studies which I looked at, which was by Dr. Saini from PGI Chandigarh, which looked to compare triamcinolone versus dexamethasone. And well, they found that the initial response to both DEXA and Tricort is very similar with the quick onset of action. However, the duration of action is much longer, as we know, because triamcinolone is a depot preparation. So the recurrences can be delayed for several weeks or months, as they found in this study. Whereas with dexamethasone, they had more number of recurrences and which came very early. So you can see that following the injection as early as 6 to 20 days, maybe the effect starts wearing off, or maybe in some patients they had a recurrence. And in these patients who had recurrence, triamcinolone seemed to work better than, again, repeating our dexamethasone. Whereas with triamcinolone, they had recurrences from as long as 180 to 290 days. Again, we need to remember that following the injection, they were treated with appropriate anti-allergic medications. So how do we give it? I will just show you a very short video, but basically what we need to understand, I think one of the, sometimes people try to inject it into the tarsal plate where it causes bleeding, and the tarsal plate itself is not the area where we are looking to give the injection. So we usually in pediatric age require some sort of anesthesia, IV anesthesia or general sedation, whereas in adults, some people can manage with giving a little bit of lignocaine after giving topical anesthesia and then trying to inject the depot steroid. So we need to evert the upper lid, as I'll show you in the video. Basically, you can put a Johnson bud below the everted eyelid and try to push and expose the conjunctiva, which is in the supratarsal space. So with the everted eyelid, the little bit of loose conjunctiva just at beyond the edge of the tarsal edge is where you need to give the injection. So as you can see here, this is the supratarsal space, probably a millimeter above the end of the tarsal plate, where below the conjunctiva is what you need to give, and you can see ballooning of the conjunctiva once you give the injection. So this is just a screenshot of what I'll show you a little later. So don't give it in the tarsal plate, don't give it into the cobblestones. That is not where the drug will have space to reach or accumulate. Typically in my practice, often I use it for shield ulcers. So in shield ulcers where the base is clear, in the early cases, maybe just drops are adequate. But once you have an opaque base, we need to understand that these are because of accumulation of eosinophilic debris or material which prevent epithelialization, and you need to debride it. So in children, you will anyway have to give them some sort of anesthesia to debride the shield ulcer. So usually in these situations, I do combine it with a supratarsal steroid injection, and most patients will recover well. And if you have, of course, a elevated plaque, again, you need to debride and remove the plaque, and then you can give a supratarsal steroid. In practice, it's very rare that you may require an amniotic membrane graft, though sometimes you might require oral steroids or oral immunosuppressive in very refractory cases. One of the most important things in practice whenever we use steroid is to rule out infection, and shield ulcers is again a situation where you can get secondary infection, and so it's always wiser to scrape if in doubt. So I'll show you just 2 cases of shield ulcer and how that injection is given. So this was a patient who had a shield ulcer for more than 2 months and he was not improving. He was on steroids, and as you can see, there is a plaque. However, I felt there was an area where there was a infiltrate also. Sorry, I'll just. So whenever you are in doubt, it would be wiser to be sure that there is no secondary infection. Now, because these patients are often on steroids, you may not be able to see the classical signs of inflammation there, but you need to have an eye index of suspicion. Normally, whenever you scrape the plaque, the base is pretty clear. So basically, we need to understand the deposition is over the basement membrane and not in the stroma. So shield ulcer, the deposits can usually be scraped off, leaving fairly healthy stroma below. In this particular case, I tried to remove the material and send it for culture. And as you can see that even after we remove the plaque, the stroma is infiltrated, which indicates that there is a stromal involvement or deeper corneal involvement as well. So actually I was thinking of giving a supratarsal steroid, but I withheld the steroid because I realized possibility that it looks infective. So this child, the culture showed Streptococcus mitis, and I put him on antibiotic fortified drops. And initially worsening is there because of steroid withdrawal, but however, the child recovered well, and of course he developed scarring. Subsequently, we tried to keep the allergy under control. However, after about more than a year or so, he again developed a very small area of ulceration, which was again refractory to giving any drops. So I just scraped at that point of time. You can see the old scar there. So if a shield ulcer is there, the allergy is there, it can keep coming back again. So you can put a Johnson butt behind, as I showed you here. You can try to push the conjunctiva to see the loose conjunctiva where you have to give the injection. And the amount of injection in the literature has been mentioned up to 0.5 ml, though I usually give a very small amount, maybe 0.2 ml or so, which is usually adequate. But the dosing in literature seems to be anywhere from 0.25 to 0.5 ml. So another patient, just to 2 minutes. Basically, this is a patient where you can see a large shield ulcer. So just to say that if you just give steroids or you just give a supratarsal injection is not adequate for a shield ulcer. So we need to gently debride it. And basically, we also need to go below the edges, which are raised and heaped up in these cases. Don't try to cut across tissue, but just gently debride to remove as much as those whitish slough-like material will be there on the surface. In some patients, you can get a clear base once you have scraped it off, but in some patients, it may still be opalescent, but you can definitely remove this material, which prevents epithelialization. Again, bandage lens in my practice, I don't normally use because very often these children rub it out of the eye, and there is always a risk of secondary infection. So you treat the allergy aggressively and debride the ulcer, and supratarsal steroid combination will usually work quite well in these patients. So sometimes there's so much of thickening and hypertrophy of tissue that you might find it difficult to figure out the margin of the tarsal plate, where it begins and where it ends, but try to give it in the loose tissue beyond the margins of the tarsus. So thank you. And I'm sure the faculty can add some more points if I'm missed any. Thank you.
Thank you, Dr. Nikhil, for a very good presentation. Would like to have comments first from Dr. Sujata Das, and then we will discuss.
Thanks, Dr. Rajesh, for inviting me. Nikhil, really a good presentation. I don't think I'll add much, but a couple of things like it's definitely a good modality of treatment for giant papillae, especially shield ulcer. And those who are refractory to conventional treatment, I'll add, if you are suspecting poor compliance, maybe that is another indication where you think patient will not come for follow-up. In my practice, I start, even if I see giant papilla, I start with topical treatment first, wait for 1 month to 6 weeks. If still does not respond, then I'll add Supratarsal steroid. And we need to counsel patient that despite injection, we have to continue with the topical medication, and we might need multiple injection. Usually it takes 2 weeks to symptomatically better, but we need to counsel again. Maybe after 6 months, we need to repeat. And definitely it reduces the need of topical steroid. And I'll prefer over systemic steroid. Systemic steroid will be my last. So Supratarsal is before systemic steroid. And it not only reduces symptom signs, visual acuity also improve because the patient is less symptomatic. And other than dexamethasone and triamcinolone, in literature, people have tried methylprednisolone and hydrocortisone succinate. These two are tried, and multiple combination also. Like one paper is there where they have done resection as well as at the same time they have given Supratarsal. And like you mentioned, the strength also, it is from 10 milligram to 30 milligram, but routinely it is 20 milligrams, 0.5 ml. I also personally have not used dexamethasone. I use triamcinolone, but dexamethasone can be used. Only thing is less IOP chances, but the recurrence will be more definitely because it is a short-acting medication. I think this much only from my side. Otherwise, there's nothing.
Thank you, Dr. Sujata. And what I feel is that whatever experience I have, I felt that, if it is indicated, then it never disappears by just a single injection. So it has to be explained to the patient that at least 3 injections will be required. I mean, that is something which I have noted in the patients wherein I have given. So then the cobblestoning reduces to an extent that the patient is less symptomatic. Any comment from other panelists?
So I think very well presented, Nikhil, like always. You pick up always some good points which you have missed in your previous presentation. So very nicely presented, and I think 20 milligrams is what we all use routinely, although a higher dose has been given. But I always like to add some suppressant agent also. Earlier I used to use cyclosporin, and now I use tacrolimus. So that has to definitely go with it. And I am more you can say less conservative about systemic steroids, because I feel in children sometimes it becomes very difficult to break that vicious cycle. And you give one shot of systemic steroids and that cycle breaks. So then subsequently it does help. I just want to ask Nikhil, have you noted cases of ptosis which are very common after triamcinolone, a few cases of ptosis that you have? In my series, I think that is the most common thing, which it could be subsequent to cobblestoning.
Yeah. Sometimes you get mechanical ptosis also, so it's difficult to say.
So that seems to increase a little bit. Maybe I thought because of steroids.
Yeah, possibly. I agree.
Ma'am, can I come in?
Yeah, please.
Yeah. So just to just ma'am was saying that about periocular steroids causing ptosis. So there are studies in uveitis where they have shown that periocular steroids do lead to ptosis. So that has been reported quite extensively. And now we have completely switched from periocular to intravitreal steroids for the same reasons. One of the reasons for shifting.
I think one of the major challenge we face in these cases, apart from the chronicity of disease and not responding to single injection sometimes, and there are, as you rightly pointed out, around 10 to 20% cases might be steroid responders, and the IOP controls can be challenging in such cases where you give like depot injections. As you rightly pointed out, and maybe we can identify these patients first. We know them because some of them will be on a steroid for long term, and there will be a history of increased IOP as such. That's the only concern I normally have in these cases. of a glaucoma, once they have a raised IOP, very difficult to control because steroid is there for longer periods at depot. So that has to be assessed very carefully in these patients. But rightly pointed out, it's one of the best treatment for a recurrent corneal, problems coming up, especially, Shields ulcer. And if you intervene little earlier than looking for a very late cobblestoning, things become difficult. So I would rather intervene early in these cases. Just trying a medical treatment doesn't suffice in all cases where you started having a giant papillage in this case. So better to intervene early so that you subside the inflammation. Maybe these patients will have a better tarsus for a longer time, and the ptosis and lid problem will decrease subsequently. And steroid would definitely cause a mechanical, ptosis, even with as rightly pointed out, the intraorbital injections also. But as far as we are concerned, these patients have so much of problem that the lid as such, lid skin, lid becomes deformed in a subsequent time. And if you give more and more injections, the deformity will also, increase further because the child doesn't respond to these steroid injections subsequently. So you may have to mechanically take off all these cobblestones by, scraping them out, or sometimes scraping may not suffice. You have to totally dissect out, remove them, and maybe you'll succeed subsequently. It's a very tough job treating these patients.
People have even described, sir, in very severe cases, mucous membrane grafts.
Yeah.
After removing the cobble.
That is, take off entire thing, put a graft, then patient might respond. The injections are short term.
Any other comment? So we move on to the next talk, and that is by Dr. Alok Sen. And very often we get to see, patients wherein anti-VEGF injections are required, and so people should know what are the do's and don'ts in these cases wherein we are injecting anti-VEGF. So let's hear from Dr. Alok Sen regarding do's and don'ts of anti-VEGF injections.
Sir, I hope my screen is visible, right?
Yeah.
So thank you so much for the opportunity, sir. And I find myself in a group of very elite teachers and
anterior segment surgeons.
And so the topic that was given for me was anti-VEGF, which, when, and how, and very relevant because as we all know, probably anti-VEGF, intravitreal anti-VEGFs are probably most widely used procedure now worldwide. So I don't have any disclosures. So if we talk about which anti-VEGFs, we have now 5 anti-VEGFs which are there in our armamentarium, of which I think most widely used is bevacizumab in our country because of its low cost. But more recently, I was reading a few days back, faricimab has been also approved by the FDA for use in DME and AMD. Having said so, in our experience with all the rest, because this is not yet available in India and we very sparingly use brolucizumab, between the three, what we have noticed is almost we have had the similar kind of results as far as all the 3 anti-VEGFs are concerned. So when you choose, you can choose either of the 3, and depending on the response, you can always switch to a better one. When I say better, it is just that it might increase the duration of response. The second question was, how do we give? So here, the most important thing is that we should give it in a operation theater. And as in India, it has been recommended that all anti-VEGF should be given in a sterile environment. A quick comment on Avastin, which is basically a multi-dose vial, where you need to be very cautious about how you store the vial, and it is important that you finish off the vial as soon as possible, probably within 2 weeks. So this is a very good article from Atul Kumar sir, which has discussed in detail about the multi-dose vial usage of Avastin in our country. More important to us is when do we use these anti-VEGF agents and when you should not. So I'll go through some of the cases where anti-VEGF is established first line where very robust literature is available. It can also be used in some of the cases as second line or an adjuvant to some of the treatments. And then we have been using it in some cases where it is not yet approved. So there are rational uses of anti-VEGFs in some cases, which I'll show. Of course, there would be some cases which I'll show that it is useless or has no role, and in few where it can actually harm. So my whole talk, rest of the talk would be case based on when do we use and when we should avoid using anti-VEGF. So this is a case where you see this grayish membrane, the posterior pole, and the subretinal membrane. This is a case of CNVM. So I think anti-VEGF was the first approved for use in CNVM, and you can see from this slide when we treated this patient with 3 doses of anti-VEGF and how is the response. You can see the angio-OCT also showing that almost the whole of the subretinal neovascular membrane is gone with 3 injections. Here is a case where you can see this subretinal blood over here, and there is a large area of pigmentary alteration in the posterior pole. So if you see the FFA, it shows a stippled hyperfluorescence in the late phase of the FFA, and this is an ICGA picture which shows 3 polyps over here. So this is a case of PCV, and you can also confirm this on OCT where you see the subretinal blood, these PEDs which are quite high, serous PED, and you have this subretinal fluid as well. And this patient was treated with 3 injections of Lucentis, and this is post Lucentis ICGA where you see that the polyps have disappeared. Although this is not always the same, and most of the studies have shown that PDT is more effective than anti-VEGFs in closure of these polyps, but we have seen that they do close with anti-VEGFs as well. So the pointers are that in neovascular AMD, anti-VEGFs are the first line of treatment, and it is very important to understand that you have to start really early and treat aggressively. These are very important in neovascular AMD. So even if the vision is 6/6, you need to treat the patient, unlike in DME where I'll show cases where you can safely observe. So another important aspect is how long and how frequently you need to treat. Of course, the studies have shown that continuous treatment yields best outcome. However, it is not always practical, especially in resource limited country like India. And so you have to choose the interrupted treatment, of which treat and extend probably works better than PRN regime. The important thing is to remember that you do not tolerate fluid, any amount of fluid in these cases, because fluid is the one that causes vision loss on long term. Of course, in PCV, as I said, PDT probably in conjunction with anti-VEGFs would work better. Myopic CNVM is another indication for which anti-VEGFs have been FDA approved. So here is a case where you can see this membrane right at the posterior pole, and on OCT you can see that there is some amount of fluid over here, very few cystic changes. So one thing that you must remember on myopic, about myopic CNVM, that they may not harbor huge amount of subretinal fluid, and they are more picked up on FFA, where the FFA shows leakage. This is the pre-Avastin and the post-Avastin FFA. And you can see that significant decrease in the amount of leakage vis-a-vis OCT, which shows almost similar or a very small change in the raster scan. You need to do an FFA, and sometimes you need to check during the follow-up also whether more injections would be needed. Good thing is that in these cases respond very well to anti-VEGFs. Now with the availability of OCT angiogram, it has given us another tool by which you can follow up these patients of myopic CNVM. Here is a case of a diabetic patient who presented to us with diminution of vision, and you can see that there is hard exudates in the posterior pole. There are hemorrhages. There is some amount of retinal thickening over there, and this is a case of DME. So DME is one of the most common indications for treatment with anti-VEGFs, and you can see here this is pre-Avastin and post-Avastin, and you can see that the vision has improved considerably with just one injection of anti-VEGF. For center involving diabetic macular edema with the vision less than 20/40, anti-VEGFs are probably the first line of treatment. Here is another case of diabetes who presented to us with vision of 6/6. There is some amount of center involving OCT. However, since this patient had 6/6 vision, so central involving DNE with preserved vision, we thought of just observing this patient, and over a period of 3 months, you can see that the vision has remained the same, while the edema has been fluctuating a little. So for central involving diabetic macular edema with normal vision, or the patient is not complaining at all, what you just need to do is to treat the systemic issues of the patient and not worry about the edema. You can start treating once the patient start complaining and about vision loss. So in PDR, here's a case of PDR where you can see this bunch of neovascularization over the optic disc. In this case, now PDR, recent studies have shown that anti-VEGFs probably have similar efficacy as PRP, and there is lesser risk of vision loss, especially if there is an associated DME. So this case we treated with, because this had a DME as well, we treated with anti-VEGF, and you can see with just one injection, the vision improvement was significant with the resolution of macular edema. And what has happened to the neovascularization over the disc is that you can see that there is significant reduction in the aggressiveness of the neovascularization. However, off note is that once the effect of anti-VEGFs wanes off, the neovascularization comes back with a vengeance, and hence these patients need to be monitored very closely. And hence it is important that in our scenario where the patients are unlikely to come follow up, these patients should be treated with adjuvant or treated with PRP, not adjuvant, PRP primarily, and adjuvant anti-VEGFs, so that in cases where there is macular edema. So in DME, they are the first line of management. We need not give treatment to patients with DME who do not have symptoms or do not present with vision loss. It can be used as an adjuvant to PRP in patients with PDR who have associated diabetic macular edema. And it has to be avoided in patients who have a lot of fibrosis and TRD, and I'll show you why after a few slides. So here is a case who presented to us with hemorrhages in the a wedge-shaped hemorrhage in one quadrant, the superior quadrant, and there was a hemorrhage and edema in the at the posterior pole as well. So this is a case of macular tributary vein occlusion, and you can see that there is a subretinal fluid cystoid changes seen on the OCT. Now this patient received one Avastin. Following Avastin, there is complete resolution of macular edema. Another case here is this has a classic case of a CRVO with macular edema, and we treated with Avastin, and at 1 month follow-up, there is a resolution of edema. But one has to be aware of the fact that once the treatment effect wanes off, the macular edema is likely to come back, and so you need to follow these patients closely. Another indication for anti-VEGF in these patients would be anterior segment neovascularization. So here is a case who presented with the, so we'll just move on to some of the cases which are not approved because they are rare for approved indications for anti-VEGFs, but we have been using them in our routine practices. So here's a case where who presented with the peripheral telangiectasia. You can see over here the telangiectic vessels with a lot of exudations in the periphery, and there where you can, the FFA very classically shows these bulb-like telangiectasias with a lot of capillary non-perfusion areas in the periphery. So this is a case of Coats disease, and we treated this patient with multiple settings of lasers and Lucentis, and this is after a 6 months follow-up. You can see that there is quite a good resolution of the disease activity in this case. So it is known that there is an increase in VEGF level, whether it is primarily responsible for the disease itself or whether it is because of the capillary non-perfusion, which is part of disease process. But there is a significant increase in VEGF levels in these eyes, and sometimes there could be even macular edema secondary to increased VEGF levels. So, and that's the rationale for use of anti-VEGF in these cases. Of course, it is used as an adjuvant and not as a primary treatment. And as I said, that it has to be used in caution in some of these patients where there could be a lot of fibrosis, as it can lead to TRD. Another case where you can see a lot of pigmentary alteration in the posterior pole. And FFA classically shows multiple hyperfluorescent leakages with a lot of RP window defect, and what you also see is this water tracks which are there. This is a case of chronic CSCR, and you can see on OCT there is fluid and there is a separation of RPE from the Brooks membrane, as you can see over here. And this patient was treated. We tried treating this patient with anti-VEGF, and after 4 weeks there was slight reduction in the amount of fluid. Here's another case of CSCR. You can see here there are some hemorrhages in the posterior pole, and this FFA picks up this membrane in the posterior pole. You can see this membrane, and there are a few leakages in the periphery as apart from that membrane. You can see the leakages all as well. So this was a case of CSCR which also had this CNVM, and this patient also was treated with anti-VEGF. So in CSCR, anti-VEGF, the studies have shown, and meta-analysis has shown that anti-VEGF is no better than observation, at least in acute cases, because acute cases usually tend to resolve spontaneously. There is a possible role in chronic CSCR, which leads to decrease in CMT and SRF, but usually the visual acuity is not largely benefited. But there is a definite role in patients where there is a presence of CNVM. So in CSCR with CNVM, you should definitely treat these patients with anti-VEGFs. Of course, you need to be very careful to identify CNVMs, and also sometimes what now we see with pachychoroid disease is the pachychoroid neovasculopathy, where you have these double layer sign, which was seen in one of the cases with fluid. Probably the Octa gives you a better view of the neovascular membrane, and those are the patients who would respond better to anti-VEGFs. So now we come to certain cases where your anti-VEGFs will not work. So this is a patient who was treated with multiple injections of anti-VEGFs. And when you see the OCT, what you see is that by and large, this has become chronic edema, and there is a structural damage present. So even if you keep treating this patient with any amount of anti-VEGFs, it will not help much. So once you have this kind of structural damage, and now what has been described as trill is the cases where your anti-VEGFs is unlikely to yield any good outcome. Another case, this is a case of CNVM, and you can see this scarred large subretinal membrane. So even these cases, you can see this on OCT, you have outer layer tubulations, and these cases usually would not respond to any amount of anti-VEGFs, and the vision will not improve. So you need not treat these patients. This is a case who presented with certain diminution of vision, and you can see that there is a sectoral hyperemia of the disc. There is macular fan. This was a case, and the FFA shows a diffuse disc leak. So this was a case of non-arthritic ischemic optic neuropathy. And although there are studies which anecdotal reports which have shown good response of anti-VEGFs with improvement in vision, in the natural course, many of these patients will have improvement of vision. So whether it is the natural course or whether the anti-VEGFs have worked, we don't know. More so, anti-VEGFs in these cases might be deleterious as well, because it can cause spasm of the capillaries, and also because in these cases there is a low perfusion, and if you increase by giving anti-VEGFs, you might increase the intraocular pressure, which can further cause damage. So in NAIN, you have to be very careful not to inject anti-VEGFs in the eye. Of course, there are certain other diseases where anti-VEGFs do not work. Here is a case who presented with diminution of vision, and what you see is this grayish discoloration with some yellowish pigmentation over here, and this on FFA you can see that there are telangiectatic vessels with capillary non-perfusion and leakages. This is a case of MacTel, and you can see this classic ILM drape sign which you see in MacTel. So there is leakage on FFA, however there is no fluid, there is some tissue loss, and these are the cases which at times are incorrectly treated with anti-VEGFs, and anti-VEGFs do not work in this. But of course, these cases may also present with CNVM, and that is when you would like to treat with anti-VEGF. So this is my last case. Here's a patient who presented with a large polyp superiorly and inferiorly with a lot of fibrosis, and was given anti-VEGF, and this is what happened after anti-VEGF treatment. And this is what is known as crunch effect of anti-VEGF, and primarily because there is when you give anti-VEGF, the VEGF activity is stopped, and there is in the tissue there is a fine balance between VEGF and the collagen growth factors, so which goes unabated and leads to a lot of fibrosis, and that can lead to tractional detachment. So, and that's the reason why we tend not to use anti-VEGFs alone in patients with PDR, particularly when there is a lot of fibrosis in these eyes. So to summarize, anti-VEGFs are widely used agents in retinal and choroidal vascular disorders. To our experience, and most of the studies so far have shown that all anti-VEGFs work equally well. You have to be very careful not to use these patients in presence of extensive fibrovascular proliferation, as it can lead to a progression of TRD. And also, for the same reason, you don't inject in these agents blindly in eyes with vitreous hemorrhage without ruling out TRDs. So thank you again for the opportunity, and I would be happy to take up questions.
Thank you, Dr. Alok, for a very nice presentation, and very clearly you have stated that there are certain wherein it should not be injected, and one should understand the do's and don'ts of anti-VEGF injection, understand when it should not be given, and then only one should use. So it should be used in experts' hands and people who do understand the posterior segment pathology. We have Dr. Raju Sampangi from Bangalore and would like to have his comments on this.
Very good evening, sir. At the outset, I would like to thank Dr. Rajesh Sinha, sir, for inviting me. It's indeed a privilege to be in front of my teachers after 20 years and sharing the same platform. My pranams to Titial sir and Namrata madam. And Dr. Alok, it was a very nice and very practical presentation. I liked it. Especially, you made it very clear when one should use the injections and one should not use them. That was very important take-home message for the practitioners out there. One thing that I would want to stress upon is actually the injection technique itself. So intravitreal injections are the most commonly done procedures. It is not only used extensively, it is overused and sometimes abused also. So we have to be very careful when it comes to giving injections. We can burn our hands, especially with the use of Avastin injections. So first and most important practical point I would tell is source it from very reliable sources. Don't run after the price, and get it from reliable sources, and follow the guidelines that has been told to you by VRSI, and follow them judiciously when you give them. As far as the injection technique itself is concerned, the most crucial step is the use of povidone iodine. That you should make sure that you paint the patient and allow some time to lapse before you inject, and place the povidone iodine 5% drops into the cul-de-sac at least, and it should be there for at least 3 minutes for it to work. So this is the most crucial step to reduce the risk of an infection. Preoperatively also, pre-injection also, it's important that we rule out the adnexal pathology, any infections are there. And using the povidone iodine is more important than using antibiotics, pre-injection antibiotics. So this is the most crucial step, and this is the one point take-home message that I would like to give it to the viewers out.
Yes, sir.
Thank you, Raju. Any comment from any of the panelists? Anil, can you mute yourself?
Yes, sir. Yes, sir.
So, in the end, I would like to thank all the speakers, Dr. Venkatesh, Dr. Devraj Shom, Dr. Nikhil Gokhale, and Dr. Alok Sen, all the panelists, Dr. Milind, Dr. Amrita, Dr. Sujata, and Dr. Raju, and our President, Sir, Professor Titial, Sir, and Dr. Namrata Ma'am, Dr. Rajiv, Dr. Rishi, and everyone who were present in this webinar. Would like to have concluding remarks from our President, Titial, Sir.
What to say, Rajesh? It was a wonderful, you can say, range of normally performed in the last number by, not only by specialists, by the general ophthalmologists also. Sometimes they may not really understand the important surgical tricks to safeguard the patient's eye or themselves both ways. I rightly pointed out intravitreal injections now, apart from the retinal practitioners or a specialist, everybody is injecting, without realizing where it is indicated, where it is not indicated, what harm can be done. And I think the lecture by Dr. Alok was very nice. I think it really pointed out the real indications, where it can work and how does it really affect the outcome. And I hope that though in our ISCARIS, this would be I think one of the unique talk in the entry segment society, but everybody should understand this. And very nicely covered. And Raju also put very nice points in this. I was always curious to listen to these type of talks, because we never have a time and sometimes the association with these people to really listen to these talks. So thank you, both of you, for making this very, very interesting talk. And the Botox talk was also new for us. We knew that some indications in areas which we understand, especially what Dr. Amrita talked about in the paralytic squints. We know that area, but other areas are totally new for us. So that also was very interesting for us to listen to, apart from our own area of, subtarsal injections, the steroid, or the syringing probing. They were very common things for us. So thank you. It was a very nice interactive session. We have learned so many things today. And I think we are now getting into a wider range of ophthalmic practice. Because the small things require some much more importance so that we do and create the things in a nice manner. Thank you again, all of you. It was a very nice.
There's just one question if you can take up for Dr. Venkatesh, and that is that do you use endo illumination to see the probe in nasal area to rule out pediatric patients?
Generally, if you have it, then it's well and good, sir. If you don't have it, a direct metal to metal touch or the dye test, generally either betadine or trypan blue, what sir was telling, would be fine enough. So if you have that luxury, like seeing through an endoscope or something, that's it confirms everything.
There's one more question, that how exactly we should do sac massage?
So generally what I practice is, especially in a child, I ask them, mother, whenever the child is being fed, during that time, the child will be more cooperative rather than doing other times. And I ask the parents or mother to do sac massage only twice in a day, so that the sac should get filled up, because mainly through hydrostatic pressure, you are pressing the sac, so that with that hydrostatic pressure, the membrane breaks off. If you are doing sac massage multiple times, if sac is not getting filled up, then the purpose of sac massage doesn't serve the purpose. So give a time so that at least 12 hours gap, I generally give it, so that sac is completely filled. And in a single pop, sometime the mother can hear it also. If they press it properly, occluding both the puncta and pressing it downward on the sac area, if they can feel that, sometime in a single 1 or 2 sittings only, the sac opens up, and within weeks time, whenever we ask them to come for the follow-up, they tell that watering has almost gone actually. Very rarely, like some individual where it is not rupturing with sac massage, then usually at the age of 1 year, we take them for syringing and probing.
Okay, so thank you very much to all the speakers. Thanks a lot to all the panelists, our IT team led by Bageshwar, our staff, Anil Kumar, and of course the sponsor IPCA for this webinar. I thank you all, and a very good night to all of you.